Okay, good evening, everybody.
Good evening.
Welcome to my PCOS, my webinar on PCOS, new approach to diagnosis and treatment on December 7th, 2025. Our outline tonight is what are the symptoms of PCOS or polycystic ovarian syndrome? How is PCOS diagnosed? What labs are needed to diagnose and follow PCOS? Is there a PCOS diet? What medicines can be used for PCOS? What supplements can be used for PCOS? And what is Symmetra? PCOS is common, but doctors that understand it are not. 1 in 10 women approximately worldwide have PCOS. PCOS is an endocrine disorder that affects over 7 million women. That's more than the number of people diagnosed with breast cancer, rheumatoid arthritis, multiple sclerosis, and lupus combined. So it's a hormone imbalance in women that affects 1 out of every 10 to 15 women. It probably has several etiologies. When I was a fellow at the NIH, I was taught there was ovarian, adrenal, pituitary, and hypothalamus variants of PCOS. I think we recognize now that the ovarian and adrenal are the most common, but there's probably a component of pituitary and hypothalamic to it as well. And it has gradients between mild to severe. So some people can, again, have mild PCOS, some can have severe. Most of the society guidelines doesn't really recognize that and sort of said it's an all or none thing. You either have PCOS or you don't. PCOS is part of the metabolic syndrome, which includes insulin resistance, abnormal lipid measurements, obesity, high blood pressure, acne, facial hair growth, infertility, male pattern balding or genital hair loss, and trouble losing weight. So this figure here shows some of the effects, the signs and symptoms. We talked about the head, depression, male pattern baldness, dandruff, a face, actual hair growth, coarse hair growth, masculine features, skin, dark patches, cystic acne, abdomen weight gain, pelvis, thickening of the wall of the uterus, polycystic ovarians. Multiple cysts can be seen on ultrasound of the ovaries. They cause pelvic pain if large enough, irregular menses, and infertility. If the causes would be GnRH increase, that's why it's a hypothalamic condition. LH increased LH deficit ratio, pituitary, at least increased insulin, accompanied by weight gain, skin changes, also some fungal infections. The ovaries do not mature. You don't have ovulation or menstruation. And in the adrenals, and I want to highlight this is again underappreciated, the adrenals in PCOS are overactive and make a hormone called DHES, which is an adrenal androgen. In the ovaries and in the fat cells, estrogen is converted to testosterone. The high testosterone leads to acne, facial hair, male pattern baldness, and masculine features. So what is PCOS? Common signs include no periods or irregular periods. Other symptoms include pelvic pain, weight gain, trouble losing weight, acne, thick skin with dark patches. Half of the women with PCOS will experience weight gain, and many experience issues with fatigue and difficulty sleeping. And the other way to look at it is there's a good portion of people with PCOS that are not overweight. Hair loss is quite common and quite debilitating. And additionally, many women experience mood changes because of PCOS. So some of the symptoms we talked about include irregular no periods, facial hair, acne, infertility, can't lose weight, and hair loss or balding. There's several guidelines for diagnosis of PCOS. I find these fairly inadequate. The 1990 NICHD guidelines, a patient must have both clinical and or biochemical signs of hyperandrogenism, so you don't have to have a high testosterone level, and oligo or chronic anovulation. Exclusion of other etiologies of androgen excess and anovulatory infertility is necessary. So you have to have infertility, you have to not have a period, not to ovulate, which again seems rather severe. The 2003 European Society for Human Reproduction and Embryology and American Society for Reproductive Medicine, these are called the Rotterdam criteria or guidelines, demonstrated two of the three things: oligo or chronic anovulation, clinical and or biochemical signs of hyperandrogen, and polycystic ovaries, and exclusion of other causes of androgen excess and other causes of anovulatory infertility is needed. The 2006 Androgen Excess Society AES guidelines include a patient has to have both hirsutism and or hyperandrogenism, so you can just have one or the other. And oligo ovulation oligo or no ovulation, and or polycystic ovaries. So you really can have, two of these four things. You need to exclude other causes of androgen excess and ovulatory infertility. So endocrinologists such as me, I would say, put more emphasis on androgens. The key androgens are the ovarian androgen, testosterone, and the adrenal androgen called DHES. And I look at both of these at diagnosis and follow them during treatment. And then we look also at insulin resistance with various mechanisms. Gynecologists put more of an emphasis on the pelvic ultrasound, finding a string of pearls in the ovaries. Some of them don't even measure testosterone. And as I mentioned, PCOS has several etiologies: ovarian, adrenal, pituitary, and hypothalamic. So if you're thinking about adrenal PCOS, getting a pelvic ultrasound is probably not going to be that helpful. And again, there's gradients between mild and severe. PCOS is part of the metabolic syndrome, which includes insulin resistance, abnormal lipid measurements, obesity, and high blood pressure. And it's probably harder to lose weight if you have PCOS. But on the other hand, weight loss and healthy diet is crucial for PCOS. PCOS is associated with increased cardiovascular disease, so it's a risk factor for heart disease, like high cholesterol. Long-term health consequences of PCOS include this hyperinsulinemia, insulin resistance. There's increased risk of diabetes, obesity, hyperlipidemia, and the increased cardiovascular risk factor. And it's also a risk for endometrial cancer. The reproductive consequences of PCOS include increased menstrual disorders, extra androgens, trouble with ovulation. You don't respond well to ovulation induction, so there's higher rates of infertility. You need higher doses of ovulation induction. You have a higher rate prevalence of miscarriages, more complication of pregnancy, including gestational diabetes, and I brought in, that wasn't in the slide here, infertility. So the first thing you want to do is exclude other etiologies of androgen excess in irregular periods. These include Cushing's syndrome, which I diagnose frequently, and I make sure patients don't have Cushing's syndrome, prolactinoma, perimenopause or menopause, and congenital adrenal hyperplasia. These are all things that can give you irregular periods and potentially even a little bit of androgen excess. So the test I do is the most important two are the total and bioavailable testosterone with SHBG. SHBG is sex hormone binding globulin. And the next slides, I'll explain why SHBG and the bioavailable testosterone are so crucial. DHES, which is high in what's called adrenal PCOS. I often get a day 3 LHFSH and estradiol, especially to exclude perimenopause. We do Cushing's tests. I've talked many times about Cushing's disease. These include 24-hour urines and 11 p.m. salivary cortisols. You get a prolactin level to exclude a prolactinoma, a 17-hydroxyprogesterone to exclude congenital adrenal hyperplasia. I often get a hemoglobin A1C to look for diabetes or prediabetes. We often get a fasting insulin glucose level. And then in general, with treatment, I mainly follow the bioavailable testosterone with the SHBG and DHES levels. So SHBG is a very important hormone. It's a protein that binds to both estrogen and estradiol and testosterone. And it varies widely in patients. Sometimes it's quite low, sometimes it's quite high. So if the estradiol, SHBG is either low or high, the amount of bioactive testosterone can vary widely. And therefore, you can be fooled if you don't measure the SHBG. So I recommend really measuring the SHBG in all patients being evaluated for the polycystic ovarian syndrome. The assay for free testosterone in women is often inaccurate, especially at low levels. So what we do is we measure the total testosterone, SHBG, and the bioavailable testosterone. The bioavailable assay, both around Quest and LabCorp and Esoterics, is quite reliable. It has to do with a fractionation with assay, includes the free testosterone. The bioavailable testosterone is loosely bound to albumin, and it's basically the amount of active testosterone, how much the cells see. It's quite accurate. It really determines how much active testosterone the patient's cells or body actually sees. So a patient can have a normal testosterone but a low SHBG and have a high bioavailable testosterone. This may correlate with signs and symptoms of androgen excess, such as extrafacial hair called hirsutism or acne. On the other hand, the patient may have a high total testosterone and a high SHBG, but a normal bioavailable testosterone. So getting that SHBG and the bioavailable testosterone is crucial. SHBG is a marker for insulin resistance in obesity, and it's actually a pretty good marker for insulin resistance. In general, high levels are good for people. Good means you don't have much insulin resistance, and low levels means you have a lot of insulin resistance. And many women with polycystic ovarian syndrome have a high or normal, or high normal, even a normal level of testosterone, but have a low SHBG because they have insulin resistance. Therefore, their bioavailable testosterone is often on the high side. I use basically a cutoff for the bioavailable testosterone around 7 to diagnose PCOS. Higher than that is consistent with PCOS, and lower than that is not. Birth control pills and other forms of oral estrogen, but not transdermal estrogen, raise the SHBG and gives you a higher total testosterone than if the SHBG was normal. So these patients often have a normal or low bioavailable testosterone. A study found that birth control pills can raise the SHBG, and even stopping them for a year, the SHBG remains high. Because the SHBG is high, often the bioavailable or active form is low, and a female patient often has low libido when on estrogen, and even for a period of time after being off of it. SHBG is not affected by transdermal estrogens such as estradiol or an estradiol patch. So I usually give those if I don't want to affect the SHBG. And oral progesterones such as prometrium or Brovera may also raise the SHBG, but this is to a much lesser degree than oral estrogens. And what about testosterone and other diseases? So when patients come to see me, I'm always trying to figure out what they have, and some of the things that look like PCOS, especially our Cushing syndrome. Hypopituitarism with growth hormone deficiency has some symptoms similar to PCOS, but less than Cushing syndrome per se. Both PCOS and Cushing syndrome can lead to acne and hirsutism. But the testosterone is usually higher in PCOS, especially the bioavailable testosterone, while it's often lower in Cushing syndrome or hypopituitarism. I did a paper probably about 15 years ago or so, published that we looked at testosterone levels above the cutoff of 31, that's the total testosterone, than esoterics, as more indicative of PCOS and less indicative of Cushing syndrome. So that cutoff of 31 was helpful to distinguish the two. Now, if a patient has a very high testosterone, such as greater than 100 nanograms per deciliter, or a very high DHES, it could indicate an ovarian or adrenal tumor. It's worth getting an ovarian ultrasound or adrenal CT or adrenal MRI. But most of my patients don't have that. Other hormones that could be used to help diagnose PCOS would be a high LH-FSH ratio, higher than 3 to 1. Estradiol can be low, normal, or high in PCOS. You also want to distinguish between menopause, perimenopause. If you have a high LH and FSH, but both of them are high, and often the FSH is higher than the LH on PCOS. The LH is higher than the FSH. And you usually have a low estradiol in perimenopause. The high prolactin is consistent with prolactinoma. High 17-hydroxyprogesterone is seen in congenital adrenal hyperplasia. The high DHS is high in PCOS, and it's usually due to PCOS. For a while, there was a thought that there was a defect in one of the enzymes that synthesize cortisol, called the 3-beta enzyme, that leads to the buildup of DHES. There was a study of that none of the people with a high DHES, when they actually did genetic testing, had a deficiency in the 3-beta enzyme. So it's really the high DHES which really consistent with PCOS or an adrenal variant of PCOS. So how do you treat PCOS? There's a lot of different options, and we'll go over each one thoroughly. The Endocrine Society recommends birth control pills as the first-line treatment for PCOS. Birth control pills lower bioavailable testosterone, but not total testosterone. They raise total testosterone. They lower LH and FSH. They raise SHBG, and the total testosterone is high, but the bioavailable testosterone is low, so that's good. They give you most women a monthly period. That prevents endometrial buildup and helps prevent uterine cancer. And I think in a young woman who wants contraception, they are a good option. In an older patient, it becomes less of a good option, but a younger patient, it's pretty good. However, the disadvantage, it covers my whole slide here, there's much more disadvantages than advantages. The disadvantage of the birth control pills is it doesn't affect the insulin resistance. They can lead to weight gain. It's harder to follow the clinical course of PCOS. If you get a period on birth control pills, and you want to track if you're getting the period or not. So that's a disadvantage. They affect various liver functions, including the SHBG, cortisol binding globulin, and thyroid binding globulin, which could have effect on cortisol and thyroid tests. Some birth control pills have androgenic properties to them, which means they act like testosterone. Birth control pills lower estrogen, so the patients often, especially the progesterone-only birth control pills, so the patient often has low estrogen. This may lead to menopausal-like symptoms in women. Birth control pills affect clotting factors that can lead to blood clots. They lower the IGF-1, which makes the person growth hormone deficient. And usually on birth control pills, you can't conceive. So again, if you want to conceive, it's probably not a good option for you, at least now. Second option is called metformin. Metformin is an old drug. It improves insulin resistance. It helps with weight loss, but really not that much. It does help prevent cancers. It does lower the testosterone DHEAS, but really not that much. Also, it doesn't work that well as it's a disadvantage. It has a lot of side effects, including nauseousness, gas, bloating, diarrhea. General, the diarrhea is better with metformin ER. And if you take a low carb diet, it can lead to B12 deficiency, which I have some slides on, but it's quite common to get B12 deficiencies. Typical dose people use, and I use, is 500 milligrams twice a day, up to 1,000 milligrams twice a day. And you can use the metformin ER if you get side effects to the regular metformin. Next drug we talk about is called spironolactone. I do use spironolactone a lot. I think it's a great drug. It does two things. It lowers testosterone, also blocks aldosterone, blocks testosterone. So it decreases secretion. So you get lower levels and it doesn't work as well. So it's good for that. It also blocks the hormone aldosterone. So it works as a diuretic. It decreases some fluid retention. It works very well in patients with heart, kidney disease, heart failure. And it's a pretty good drug. It works well, doesn't have any side effects. It's probably, the medicine's one of the best ones. The disadvantage is it blocks aldosterone. It can raise potassium, especially in older patients and also diabetes. And I'm always fascinated. I have my patients with diabetes. I give them 12.5 milligrams spironolactone. Their potassium shoots up. And I take a young person with PCOS without kidney disease or diabetes, and I give them 100 milligrams twice a day. It doesn't affect their potassium at all. So there's something different about people with diabetes. It can lower your blood pressure because aldosterone is involved in blood pressure regulation. You feel dizzy on standing. You feel dehydrated. It rarely raises liver tests. I usually monitor them every 3 months, and it's reversible. So if the liver tests do go up, you need to stop it and then watch it return to normal. You should not get pregnant taking it, but I think you can continue taking it up until pregnancy. It's not that bad if you get pregnant on it compared to the next medicine we're talking about called Casodex. And I think if you're conscientious and stop taking it when you get pregnant, that's okay. The typical dose is 550 milligrams twice a day. You can go up to 100 milligrams twice a day. And you usually use lower doses at older patients and those with diabetes or kidney disease, such as that 12.5 milligram dose. Another drug that is not widely used, but it works very well, is called Casodex. It's similar to a medicine called flutamide, which I used to use. It's no longer available. The Casodex both also lowers testosterone, blocks testosterone the receptor. It is really used for prostate cancer, so it's quite effective. It's a very strong blocker of testosterone. It decreases hair growth quite well. It doesn't affect the aldosterone receptor, unlike spironolactone. Its disadvantages is it's off-label. It's really used for prostate cancer, and some people it's not FDA approved for women. So some people feel unusual taking a prostate cancer medicine for PCOS, but it's really okay. Um, it raises the liver test also reversibly. You should watch that. You should not get pregnant when taking it. The idea is if you're taking it, you get pregnant, you have a male fetus, it prevents the penis development in the male fetus, among other things. I think it has more of effect on this fetus than spironolactone. But I think, again, you're probably fairly safe if you stop it once you get pregnant. The typical dose I start with usually 50 milligrams once a day and go up to 50 milligrams 3 times a day. Progesterone is another good option. Progesterone lowers testosterone due to the feedback. The advantages of it can restore your periods. You either give it days 15 to 25 of the month or 15 to 25 of a woman's cycle. Usually if they're not having a period, I start with days 15 to 25 of the cycle, often 200 milligrams, and that helps restore the cycle. Or you can give it continuously and stop the cycle. Both of them are good for lowering testosterone levels. A lot of my patients were put on birth control pills and aren't doing well on them, but they said, "Oh, I've been on them so long, I'm really worried about going off them." Most of the patients, you can switch to continuous progesterone, like 200 milligram dose, and they'll be fine off the birth control pills. But the birth control pill progesterone does lower the testosterone, but doesn't have nearly those detrimental effects that I talked about with birth control pills. Occasionally, people get fatigue, weight gain, bloating. I usually give it at nighttime to prevent some of the fatigue. I like the bioidentical progesterone over synthetic Provera, and a typical dose is 200 milligrams on days 15 to 25 of the month or the cycle. Another drug that many doctors don't realize is a great drug for PCOS are the statins. The two main ones are called Lipitor or atorvastatin or Crestor or rosuvastatin. They lower testosterone, they lower lipids. There's a slight statistical chance of increasing diabetes, but it's pretty minor. They can give muscle aches. There's reports certainly of people getting memory problems, but overall analysis feels they help memory problems. But these are quite good at giving to start giving at lowering testosterone. Typical medicine doses are Lipitor 40 milligrams at bedtime or Crestor 20 milligrams at bedtime. The next drug that people use, and I use for PCOS, are the GLP-1 receptor agonists. These are the medicines called tirzepatide or semaglutide. They lower testosterone. They originally found for diabetes. They become major weight loss medicines. They're often expensive and usually not covered by insurance unless the patient has diabetes. And they really are not covered. I haven't seen any insurance cover them for PCOS, even though they work fairly well. I usually prescribe compounded GLP-1s, either tirzepatide or semaglutide, mostly tirzepatide. We've expanded some of our options for the tirzepatide. You can go on my website, look at my GLP-1 article. So they're good. They're helpful for PCOS. The advantages of them are lowering testosterone, weight loss, improved diabetes parameters, glycemic parameters. The disadvantages are it's expensive if they're not covered by insurance. Even the compounded is certainly more expensive than metformin or spironolactone. Side effects include nauseousness, vomiting, abdominal pain, loss of appetite, diarrhea, and constipation. And a typical dose I use is the compounded tirzepatide at 2.5 milligrams weekly. So to summarize, medical treatment for PCOS, it's often you need more than one drug. Drugs may have side effects. The drugs aren't that good for adrenal PCOS. They're better for the ovarian PCOS. And many people, in addition to the drugs or instead of the drugs, do better on dietary and supplementation interventions. We'll talk about that, nutrition and supplements for PCOS. First question is, what is a healthy PCOS diet? So there are this idea of inflammation. These are ultra processed foods, things that have, especially carbohydrates, high amount of carbohydrates, increase insulin release and trigger inflammation. This picture here shows a stack of Fruit Loops, Wheaties, cornflakes, chocolate snacks. Some of the examples are cereals, white bread, white rice, baked goods, crackers, candy, sugar drinks. These all trigger insulin release and trigger inflammation and should be avoided. And I like to show this slide. I just show this in my obesity class. Corn on the cob is minimally processed. It's basically that's what happens in nature. The corn in the can is processed. It's basically corn, but has some salt and is in a can. Ultra processed is things like Doritos. It has a little bit of corn in it, but not really too much. So you want to avoid these ultra processed foods and stick with the minimally processed foods for your PCOS diet. Healthier carb-containing foods are whole grains, fruits, vegetables. I have on my website the vegetable diet. I push 2 servings of vegetables per meal. Starches, starchy vegetables, and mostly non-starchy vegetables are even better. These are things like in the picture here: tomatoes and legumes and parsnips and carrots and apples and peppers and things like that. And beans and legumes are also a good source of protein and carb-based and pretty anti-inflammatory. And this picture here shows that eat a carb only, you spike up your blood sugars. If you eat carbs plus protein, you don't, it's less, and carbs plus protein from fat, it's even less. So planning a healthy diet, I would say no sodas, Start the day with a high protein or vegetable breakfast. I encourage people to eat vegetables or breakfast, and I do that myself. Eat regular meals and snacks throughout the day. You don't want to overeat, but you should have regular meals throughout the day. Don't want to skip meals. Include protein, fat, and carbs, and I would say vegetables at each meal and snacks. Focus on unprocessed foods. Include a rainbow of fruits and vegetables. And three-quarters of your plate should be fruits and vegetables, the grains, and starchy vegetables. Starchy vegetables might be things like potatoes and corn, beans and lentils, and yogurt and milk. And keep your carbs to like a quarter of the plate. So here's a plate I show also in my obesity class. Half the plate is fruits and vegetables, a quarter are plant proteins, and another quarter are whole grains. I think this would be a good diet for PCOS patients. So let's go on to supplements. Why take supplements? First of all, because the medicines don't work too well, and they help improve your labs, help with insulin, cholesterol, triglycerides, testosterone levels. They improve ovulation, egg quality. They lower testosterone, especially lower the adrenal hormones, DHES. They often replace diet supplements missing in your diet, such as people that are vegan that might have B12 levels. People that don't go outside might have vitamin D levels that are low. They might have malabsorption. Many people do need supplements, and they often optimize nutrition levels. There's many studies that show the metformin can cause alterations to the B12 intrinsic factor complex in the ileum. B12 deficiency is common over time. And I really try to keep my patients' B12 levels, my county job, where they have a lot of neuropathy there, nerve damage, mental health changes. So I try to keep the B12 greater than 400. It's pretty easy to do. So patients who take metformin should have their vitamin D, B12 levels checked on a regular basis and supplement their diets with B12. There's a gummy on Amazon that's 3,000 micrograms a day, and 1,000 micrograms a day is usually a good dose. You don't need shots. You don't need high doses. Usually just taking some B12 is good. So here's a couple papers on B12 deficiency in metformin. This paper here shows that metformin reduced B12 concentrations in people with PCOS and on metformin. And another paper here that they were low after just 6 months of treatment of women with PCOS taking a standard dose of metformin. One of the key supplements is called myo-inositol. It's related to D-chiroinositol. These are relatives of B-complex vitamins. They're found in foods such as fruits, beans, cereal, and buckwheat. The inositol phosphoglycin mediators are second messengers. They help with cell signaling. They regulate hormones such as FSH and insulin. They also lower the TPO antibody, so I use them occasionally in PCOS. They're helpful in insulin resistance, lipid issues. They lower androgens, both adrenal and ovarian. They help with infertility. They help with hypertension. They help with weight loss. They reduce gestational diabetes risk, and they help with egg quality. So it's quite an excellent supplement. In general, the ratio between myo-inositol and D-chiroinositol is 40-1, and a typical dose would be 2,000 milligrams of myo-inositol, 50 milligrams of D-chiroinositol. You should recommend taking it with meals. On my PCOS article on my website, there's actual links. You can go on to click on them for Amazon. But a good product on Amazon that's called myo-inositol Plus for omnibiotics. Main side effect of these are hypoglycemia. Several studies have shown that this myo-inositol improves ovulation and metabolic factors. Two double-blind randomized controlled trials using 4 grams of myo-inositol in PCOS increased insulin sensitivity pretty dramatically, decreased triglycerides pretty dramatically, cholesterol, testosterone was about a third of the level, and improved systolic and diastolic blood pressure. And 16 out of 23 women, 69% ovulated. That's really impressive medicine here. Another study here showed myo-inositol improved ovulation, substantially increased HDL, the good cholesterol, reduced body weight. 70% of women established a normal ovarian rhythm, and obese women showed similar ovulations as leaner women. So this is another review article showing that myo-inositol with chiroinositol is quite effective. And the myo-inositol is better improving egg quality than the D-chiroinositol. Studies here show that 2 grams per day of minoxidil had more follicles and oocyte maturation, and minoxidil did better than the D-chiroinositol for oocyte quality. And increasing the dose too high made a quality of ovarian reserve worse. So, again, that dose of 2,000 myo-inositol and 50 D-chiroinositol seems to work well. NAC is another important supplement. It's a antioxidant and an amino acid. It's a derivative of L-lysine. It's a precursor to glutathione. The advantage of NAC is improved insulin resistance, infertility, dyslipidemia, inflammation, androgen lowering, oxidative stress, bronchitis, and immune support. It's fairly expensive, and there's a lot of things you go on Amazon, you can find NAC. It's a lot of things that aren't NAC, but has similar names. The recommended dose is somewhere between 1.6 to 3 grams per day. Generally, obese women need 3 grams or more to be effective. One of the ones you can get on Amazon is called NAC from Now, 1,000 milligrams 3 times a day is a reasonable dose for that. Side effects include GI issues and fatigue. We reviewed 8 randomized trials with 910 women, so a lot of people. NAC improved BMI, total testosterone, insulin, lipid levels, had significant improvements in pregnancy and ovulation rates as compared to placebo. NAC showed similar benefits to metformin for improving pregnancy rates, spontaneous ovulations, menstrual irregularities, insulin resistance, and cholesterol. This was a meta-analysis, 2015. It was quite impressive of body of work of NAC. Another supplement that works very well is called resveratrol. It's an antioxidant, anti-aging. It's in anti-cancer and has cardioprotective properties. It's found in skin of grapes, berries, red wine, and peanuts. And it's the picture of the red wine up there. 30 patients with PCOS were given resveratrol or placebo. The resveratrol group had a 23% reduction in the total testosterone levels and a 22% reduction in the DHEAS levels. And again, it's very hard to have medicines that lower DHEAS, so this is definitely an improvement. Fasting levels, insulin levels drop pretty significantly. So the advantage of resveratrol, it reduces total testosterone and DHEAS levels. It can give some people gastrointestinal disease. Several sources on Amazon, including Doctor's Best Transferterol or Nutrivin Premium Resveratrol. Fish oil is also effective. The advantages are reducing inflammation, helping with depression, supporting healthy pregnancies, improve triglyceride levels, helps with MASLD, which is the new term for fatty liver disease, helps with fertility, helps skin and hair health. The disadvantages are minimal. Some people don't like the taste. You want to get the ones with the fish taste removed. There are a couple good ones on Amazon, the Nature's Bounty fish oil or Nature's Made fish oil. 1,000 milligrams twice a day to 1,200 milligrams twice a day. Now, berberine is a Chinese herb. It's used to treat diabetes and prediabetes. A lot of good literature on its effectiveness. It works basically similar to metformin with much less side effects. I have an article on my website comparing metformin to berberine. It's one of my more popular articles on my website. Berberine is given 600 milligrams twice a day as the usual advantage. It's been found to reduce testosterone, help with lipids, help with insulin levels, and gives weight loss and improves fertility. It reduces testosterone, as I mentioned. Disadvantages are nauseousness and constipation. A couple brands would be the Premium Berberine HCl by Smart Labs or the Toplex Berberine supplement. And you have to watch out for here. It's often these ones, the dose is listed as 1,200 milligrams or 1,800 milligrams, but it's that dose for 2 servings or 3 servings. So each tablet is usually 600 milligrams. In 2022, there's a retrospective randomized controlled trial comparing myostatin, berberine, and metformin. The results showed that all groups had improved cholesterol and triglycerides, but berberine actually showed the most benefits. So again, more than metformin, leads to larger decreases in total cholesterol, LDL, and triglycerides, and the biggest increase in the good HDL compared to metformin and myo-inositol. All treatments reduced weight and BMI, but berberine led to the largest drop in waist size and waist tip ratio, showing a stronger effect on central weight fat loss than metformin or myo-inositol. And these findings suggest that berberine is a good option for women with PCOS are especially focused on cardiovascular health and weight loss. Okay, the next one to talk about is probiotics. Probiotics improve insulin sensitivity and glucose control. They help with fasting insulin and glucose levels. They help with your HOMA, which is a marker for insulin resistance. They do improve your gut bacteria, which is very important. They increases your SHBG, which is good. You want to have a higher SHBG. They decrease total testosterone, free testosterone index, which reduces symptoms of hirsutism and acne. They reduce inflammation. PCOS is associated with chronic low-grade inflammation. They help with inflammatory markers like highly sensitive CRP. Probiotics help with cholesterol triglyceride levels, reducing cardiovascular risks associated with PCOS. While it's not a weight loss drug per se, they usually even associated with a BMI reduction, improved body composition when combined with dietary and lifestyle changes. I don't recommend any brand. I think most of them are reasonably okay. A couple of brands are shown in the picture here. Physician's Choice and probiotics. 60 billion is a lot. Sounds like a lot to me. 1 billion sounds also pretty good. So these are also good options. Vitamin D is also associated with infertility. When you take metformin plus a pretty high dose of vitamin D per month for 6 months, compared to metformin alone, you had the more dominant follicles, improvement in menstrual regularity. Infertile women who underwent clomid stimulation had more follicles and were more likely to be pregnant when they had higher vitamin D levels. And vitamin D supplementation lowers abnormally elevated serum AMH levels. So again, vitamin D looks like a good option. Also for people, you want to keep your level basically between 30 to 50 for most people. It's important to recognize that these two hormones are different, DHES and testosterone. DHES is an adrenal hormone. Testosterone is an ovarian hormone. And there's not that many medicines that lower DHES. Glucocorticoids like dexamethasone can lower DHES, but they have way too many side effects for use. So therefore, these supplements are really good at lowering DHES and have an important role for that. Okay, and this brings us to Symmetra. Symmetra is a blend of supplements that have been shown to improve PCOS that I showed before. It's basically 5 supplements: minoxidil, D-chiroinositol, resveratrol, berberine, and probiotics. And I think you can see that all 5 of them are quite effective at lowering testosterone and also DHES. Put them together, you can get them all separately on Amazon, but cost adds up. And I don't know, some of the quality might not be the greatest. So we're coming up with a product called Symmetra. That's a powder that has all 5 of these in it. It's going to be in a natural berry flavor. It's going to taste very good. It's going to be certified gluten-free, soy-free, dairy-free. There's a certification called NLEA that all the ingredients listed are present. I'm going to recommend 1 scoop for mild PCOS and 2 scoops for more severe PCOS. I think it's going to be better than any other PCOS supplement on the market. Again, as I mentioned, it has these 5 ingredients that are all powerful, helpful for PCOS. People can on their own buy separately NAC um, and fish oil that's not listed in here. Um, they can take progesterone, things like that. They take the medicines, but this has the main ingredients that are potentially good. And once I get this made, we'll do some studies on it. My guess is this will very easily be better than any of the drugs and probably lower the androgen levels by at least 50%. So overall, I think I have a unique approach to PCOS, combining medicines, supplements, and diets. If you're struggling with PCOS, make an appointment at Good Hormone Health. The medicines, spironolactone, progesterone, Casodex, GLP-1s are all good offerings, often together. Anti-inflammatory foods in sensible portions help slow carbs. With slower carbs, more complex carbs can help. Supplements, when added to a healthy diet and lifestyle, can offer health benefits and help with ovulation and help with lowering the levels. Symmetra is likely to be a breakthrough for PCOS treatment. In the meantime, we have my article. It should just be posted at the top of my website. It's updated on PCOS. They all have links on where you get your supplements on Amazon. So please visit my website. The talk should be posted in a couple of days. It's also going to be posted on Facebook. It will be a podcast on my podcast channels: Spotify, Apple Podcasts, iHeartRadio, Podcast Addicts, and Amazon Music. And if you have any questions, please send us an email. Okay, so probably we have most of our patients on Facebook. So if you want to start reading them off, Jamie starts with a question here. We could start with her. Jamie says, thank you for this. It's safe to take berberine in addition to metformin and Mounjaro. Or is that too much glucose control? I would say it's not. None of them really give you hypoglycemia. And there was a study looking at berberine plus metformin. They do work synergistically. So metformin, lowers your, for example, glucose levels or A1C. Berberine lowers it, and together they lower it even more. Mounjaro in general also doesn't lower it too much. But if you do get hypoglycemia, you may need to back off. Stephanie, do we got any questions on Facebook?
Sorry about that. Thank you. Yes, we do. So let's go with the
Try to
first
speak up
one.
a little bit.
Oh, can you hear me?
A little louder.
Okay. Can you hear me better now?
Yeah, that's better.
Okay. AK says, Dr. Friedman, after my fifth surgery for endometritis, my REI told me endometritis doesn't change form into recurring ovarian cysts and something else is going on. I was already having SXS of A1, but didn't know. Later, developed hemorrhagic endometria and ovarian cyst was ruptured. What would cause this? Is this PCOS? I was 89 pounds.
Probably not. So, endometriosis and PCOS are different diseases with different etiologies. It sounds like you more have the endometriosis problems than the PCOS. Most PCOS patients are overweight, but not everybody. But, I think you want to either come see me or have your doctor check your bioavailable total testosterone and DHEAS levels, which is the best way to see if you have PCOS or not.
Great, thank you. Danielle asks, Hi, Dr. Freeman. Is there a reason some women might have hard time absorbing certain vitamins? I always have low vitamin D, even though I work outside. I've had to be on and off supplements since pediatrics. Would a hysterectomy essentially cure POS? Thank you.
Okay, so first of all, most people have low vitamin D levels. Um, you can be outside the sun, but most people don't go in a bikini outside the sun. They wear clothing, so they just have a little bit of their body exposed. So I probably being outside is not going to make that much of a difference. Most people need a fair number of vitamin D replacement. Um, in general, you just want to take enough to get your levels up high. If your levels aren't high, I would take more of it. And some of my patients take 20,000 units a day, and some of them take 1,000 units every couple of days. So I think the main thing with supplements like vitamin D is take enough that you need. If you did have, like bariatric surgery in the past, which doesn't sound like you did, or like some kind of GI issue, you probably need more. But in general, I think I would just recommend taking what you need and monitoring your levels. A hysterectomy by itself would not help PCOS. A hysterectomy with ovarian removal would, but it's quite drastic. I mean, I think you can take the supplements and the medicine be over that. In the old days, they did a procedure. They took a wedge out of people's ovaries to help with it. Worked okay, but it's sort of primitive when you have the supplements and medicines that are much better.
Thank you. Another question. I missed the first half of the talk. I'm interested in knowing if how PCOS impacts the body after ovaries are removed. Are these supplements like myo-inositol still beneficial without ovaries?
So as I mentioned, sorry you missed it, but there's both ovarian PCOS and adrenal PCOS. So adrenals make the hormone called DHES, make DHEA gets converted to DHES, and people can have DHS high, testosterone high, or both high. So if you had your ovaries removed, your testosterone will probably be quite low, but your DHES may or may not be high. So it's worth checking the DHES level. If it's high, you may want to go on some of these supplements like myo-inositol to try to lower it. If your DHS is not high, I think you're probably okay.
Awesome. AK said, thank you. I am your patient and you have and continue to be most helpful.
Sure, my pleasure.
the questions I have for now.
Okay. Any other questions, anybody?
Let's see.
Okay, we'll see everybody next webinar.
Thank you so much.